So I am a radiographer by trade, so yeah, I'm here to share experiences. So I work for a company called Genesis Care in the UK. Genesis Care is a global organisation. We've got 86 LINACs spread across 3 countries at the moment, with a look to expanding into other countries. In the UK, we've got 10 centres. We've got 7 bespoke radiotherapy centres, which are single LINAC centres, linked onto private hospitals for access to diagnostics, chemotherapy, medical services. We've got 3 bespoke medical centres which offer the full package, and we employ more than 150 employees. We've been doing DIBH for about 3 to 4 years now, so that's not a new technique to us. We haven't been doing it, obviously, with SGRT. So I'm going to talk to you a little bit about what we've done previously and also what we've moved towards doing now. We offer treatments such as SABRE, VMAT delivery. We're looking at implementing SRS over the coming months. And also we offer a living well patient experience. So we offer all the holistic care that isn't often offered in the UK. It's important for me to put up this slide. This is our sort of vision and value statement. This is a global statement. It's something that Genesis Care use for every sort of new service implementation, any change in practice. Everything that we try to implement has to come back to this value statement here. So we have to make sure that everything's measured against quality, access and efficiency. We want to try and always improve patient experience, improve access, whether that's through amounts of patients that we can treat on our machines per day, or whether it's capturing patients that haven't got easy access to radiotherapy. And also from an efficiency point of view, we want to see efficiency gains, so whether that's shorter treatment times, improved throughput on the LINACs, or whether that is actually improving a technique so that we can free up radiographers or other technical staff to spend more time with patients. So me introducing SGRT in the UK, everything fell back to this slide, and you'll hear me make reference to this as we go through. So breath hold treatments, as I've just said, we have been doing that for quite a long time. We've found it removes error in treatment delivery, as obviously our patients aren't breathing as we're delivering the beam. It is quite a lengthy procedure for us, or has been up until now. Our patients all attended for an hour's preparation session prior to their CT scan, so we could coach them through. So from a resource point of view, it's quite radiographer resource heavy. We carry out 2 planning scans, one in free breathe and one in breath hold, actually probably to answer the question that was raised earlier, so that if a patient becomes unwell during treatment, or actually they can't cope with the breath hold, we have 2 plans so that we can revert to a free breathe plan. We do daily on-treat imaging, so we do a fast scan or a mini XVI scan or CBCT before we treat daily and make those corrections. And yeah, as the data says, free, deep inspiration breath hold, it reduces dose to mean heart. So similar kind of pictures to the ones that Dr. Powell showed earlier, just the difference between a normal free breathing scan and a full inspiration. And this was our previous method of delivering DIBH. So we used the Dynar kit, which consisted of a spirometer mouthpiece, also a nose peg, and then virtual 3D goggles. So we actually, although it was highly effective, and it was highly effective, we've published results using this system, and we're very, very happy with the clinical results. From a patient experience point of view, it's pretty grim. So patients would have a prep session, as we said, where we would coach them in how to use this equipment. You can see along the bottom of the slide there, that's the coaching bar that the patients see in the virtual goggles, and also that the radiographers see outside of the treatment room. So once we can see that the patient's in sort of a nice, relaxed, steady breathing pattern, the radiographers would hit a green light outside the room, so traffic light system, and the patients know to take that breath in whenever they're ready. So with the Dynar system, it isn't a forced breath hold. The patient does remain in control of that, and they can breathe out at any point. However, it's fair to say it's not a gated system, so there's a heavy reliance on the radiographers watching the patient all the time. There is an alarm sound if the patient breathes out of that green bar, so that the radiographers know to turn the machine off. So although we were very, very happy with this system, we thought from a patient experience point of view, we wanted to look to see if there was something that we could do that would be better than this current offering. So again, similar slide to one shown. I'm sure you're going to see a lot of these over the course of the next 2 days. But again, it just shows the effectiveness of breath hold. So why did we choose Align RT for breath hold? So there's lots of published data out there. A current study by Zyga has been, has actually shown using Align RT with breath hold is really, really good, with 0 cardiac incidents after 6 months in comparison to 27 without using some kind of DIBH system. We've sort of accepted and appreciated that for the last few years. So as I said, we have been doing DIBH, so that wasn't something new for us. So why at Genesis in the UK did we choose to go down this route? We wanted to enhance our technology offering, improve our safety by adapting something that was a gated system, and we wanted to improve our patient comfort. We wanted to improve access and efficiency across our network of centres. So one of our centres in the UK, in Nottingham, actually we couldn't fit the Dynar kit through the CT bore because we had a narrow bore CT. So in using SGRT, we were able to not send those patients somewhere else for their planning scans, which has helped considerably. We wanted to improve our breath hold system across all of our sites. And we wanted to sort of get rid of our Dynar prep sessions, freeing our radiographers up for more patient-orientated tasks. And also we looked at SGRT from an offering into further complex treatments. So we're already delivering SABRE. We wanted to be able to monitor those SABRE patients better, but we also want to look towards working with our doctors that are treating SRS cases in their NHS trust to actually start delivering them privately with us. And we wanted to build a bit of a reputation in the UK. The UK haven't adopted SGRT widely yet, so we wanted to sort of try and lead the way with SGRT. So I came to this conference last year and sat in the audience as a real skeptic, it's fair to say. I was not convinced. So after the conference, I went away with a different viewpoint on it all, and I wanted to not only look at Align RT and Vision RT, but actually wanted to look at all the other manufacturers out there that were delivering this to make sure that we chose the right one. I looked at CRAD, I looked at Humedic, and actually we met with the vendors, we had demos, we went one step further, and we actually took a multidisciplinary team out to do site visits, reference site visits. We interacted with the staff that we use in these systems to find out, we wanted to ask all the questions you ask the manufacturers and they tell you it's all fine. But we asked them about downtime, we asked them about how easy they found the system, we asked them about their training, future plans for use of it, what they'd managed to do in a short space of time with the technologies. And we, after doing all of that, went ahead to install the system on an audit basis at our Nottingham site. It was quite important for us as well that the company matched our own vision and values, and we discussed sort of future, what they wanted to work on in the next sort of 6 to 12 months. With most of our sites being single LINAC models, it was important for us that downtime was very small. We didn't really want any form of downtime at all with the kit we installed. If our machines go down, we don't have another machine locally that we can transfer patients to, and it then involves our patients having to drive 1 or 2 or several hours to another site for treatment. So yeah, the technical and engineering support was key. So the device overview, I'm not a physicist. I can give you a bit of an overview into it. The system that we've installed at Nottingham is the HD camera system. We have 3 of these pods mounted into the bunkers in the ceiling of the bunkers. I like to think of the image sensors as eyes. So it's two eyes looking at your patient all the time from 3 different directions. So it creates about 20,000 reference points or 20,000 virtual tattoos is how I sort of managed to get my own head around it. The system projects a pseudo-speckle pattern onto the patient, which you can see here on this slide. And also you can see the screen readouts there showing your offsets. So we like an audit in the UK, as we do everywhere, but we needed to try and answer some of the questions that we'd raised. We didn't want to proceed with this system just because it looked like the latest bit of kit and we were all a bit wowed by the technology. We wanted to make sure that if we implemented this for our breath hold patients, it was as good as, or the clinical results were as good as, if not better than our current offering. I wanted to look at open face shells. have a lot of patient feedback. We have feedback after a week of treatment. We have feedback constantly throughout treatment. And then also we follow up our patients for about 6 months after. And one of the main things that came back from our head and neck patients was they really hated the shells. So from a patient comfort perspective, we wanted to test that. And then we also wanted to think about the accuracy of doing that in trying to implement SRS. And we also wanted to assess the use of the system against getting rid of our tattoo setup. So, excuse me. So in the UK, I'm sure pretty similar. We tattoo our patients, we align to lasers, we make shifts. We wanted to see if we could actually move away from a tattoo setup at all and using the virtual tattoos for that patient positioning. So my results are not as technical as Dr. Powell's, but this is just a very small sample to show sort of the process we went through to try and answer those questions that we raised. So when we installed, we had a very quick install. We had a bit of training with a couple of our radiographers, but actually the system was very, very new to everybody. So what we did initially was we ran both our spirometry-based DIBH system and Align RT system together. And everybody ignored the Align RT system apart from me. And we audited. Now, this is just three sample results here. We've got hundreds that we'll look to publish later on, but this just gives you a bit of a guide of what we saw. So setting up as normal to our tattoos and lasers in the room, making our shifts to isocenter, I recorded what the Align RT software told us where we were on the patient before we did our daily cone beam CT, both in breath hold and out of breath hold. So we set up to free breathe in the room. I took those coordinates off the Align RT software. Patient went into breath hold in the room. I took the results off the Align RT software. We went out and did our XVI shifts, and we compared what our cone beam CT told us to what we actually saw in the room. And you can see here that the results were all within a sort of millimetre of what the Align RT software told us in the room. So we did this over and over again for several patients. And then moved on actually pretty quick because the results were fairly apparent that what the XVI scan was telling us correlated with what Align RT was telling us in the room. So from there, we moved on to actually making those shifts in the room. And I think for the therapist, that was a real step, actually convincing them to move away from those set prescriptive shifts that have come from a treatment planning system was really alien. It took a lot of coaching. It took a lot of sharing results like this with them to make them believe in the system. But you can see here on free floating the bed, so we would set up to our lasers, we would make our shifts, and then we would actually use the Align RT software in the room to make those final corrections. And then when we did our cone beam CT following those corrections, we were pretty much perfect on every patient, which was fantastic. So you've seen a couple of these pictures. I won't labour on this, but this is just to show you the ROI that we've drawn on one of our breast patients, and actually us monitoring her there in breath hold. Really, really accurate, obviously, a gated system, which is a real safety plus. So technology to improve patient care. I'm sure you're all aware and have seen horrible systems like this. I used this about 10 years ago in previous life. Horrible experience for a patient. Not something that we want to try and implement at Genesis Care for sure, with some of our centres not even being based on a hospital site. So again, looking towards moving to an open face shell system. We don't want to have our patients in clinic with us for 12 hours. Our patient appointments are about 15 minutes per patient, 15 to 20 minutes, and we wanted to try and keep that going, thinking about SRS. And understanding the accuracy of the system as well has helped us to sort of feel a lot happier about exploring this further now. So here we go. It's just a couple of studies there. You'll have those on your stick if you want to look at them. So we actually reviewed, again, all the open face shells that were on the market and went for the macromedic style shell. We found that from a rotational point of view, this shell, with it having a back shell as well, was really, really, really good. Plenty of visible tissue without overstretching the shell. And this shell's actually made from a slightly different material, so it doesn't overstretch. So it's very, very sturdy, it's very solid. And our patients sort of reported back that it was very comfortable to sort of wear as well. And again, we did a similar kind of audit with these. So we looked at setup accuracy. What we found interestingly was with using the Align RT software, we picked up a lot more rotations. So again, we saw reduced repeat imaging. We were able to correct for those rotations in the room before we went out and did our CBCT for the day. And we're not actually doing any form of repeat imaging for these patients, or sort of the ones we've seen so far. This probably was the most emotive part of our audit to date. I'm sure you've all had patients in the past that have come in for treatment, and when you've told them they're having tattoos, this is what they expect, and they get a bit of a shock. Although a little bit funny, and we joke with patients about this in the UK, that's really something that troubles women, especially. They feel self-conscious about having tattoos and wearing V-neck tops, wearing swimwear. And although we've not really discussed that with them up until now, because it's just expected, this is what we have to tattoo you, that's what you have when you have radiotherapy, when we've actually talked to some of our patient groups and got feedback from past patients, almost all of them said that they would have preferred not to have treatment tattoos than have them. So that's something you can't ignore once you've asked the question. So although our tattoos are tiny and they look like this, some therapists are better than others at doing them. They are tiny, but they are a permanent mark of a journey that most people don't want to remember. We sort of accept that when their treatment's finished, that's fine. But for most of the women that we talk to, this is a constant reminder of the most awful period of their life. And actually, it's right at the end of most of the patients' journeys as well. And it seems slightly cruel to leave them with that sort of lasting mark. So we've moved, with the help of one of our most experienced radiographers at our Nottingham Centre, where we installed, to delivering a patient a tattoo-free treatment. Very, very early days in the audit. We've done about 10 to 12 patients now, but we've found from the audit results so far, obviously, of which we need to collect a lot more, is that the setup is as accurate as using a tattoo system. And I expect as we treat more and more patients in this manner, we'll see an increased accuracy using 20,000 virtual tattoos rather than the 3 to 5 that we would put on them normally. So in installing this system, I think it's fair to say we've also found that we've had a lot more information that we never thought we would see. We now see that patients do move. They move when we're analysing our cone beam CTs. They move when we press the interlocks. They move when they think you're not looking. So all of these things, and this system has allowed us to make those adjustments back to where we know that they're in the right position without having to re-image. So from a radiation point of view, not doing those repeat images all the time and actually spending the time resetting up the patient is really, really good for us. We're now going to look at exactly how much intrafraction movement that there is per treatment delivery. So we're going to start auditing the amount of times that the machine actually gates off for every body site. We want to do future work, obviously collect more data for our tattoo-less patient setups. We want to now look towards reviewing our imaging protocols, because at the moment we do a CBCT daily for these patients, but seeing the accuracy in the results that, we could potentially start to look at maybe imaging for the first 3 days and then weekly, or move over to a quick 2D image. That's something that obviously will have to be taken up through our doctors and things. And we want to report on treatment outcomes for these patients, which is obviously a way down the line, having only been using this system for 6 months. We want to look at treatment margins. That will obviously fall to our physics team and our doctors to start looking at that. I can't answer whether we will be able to do that, but it's certainly something to look into now. We want to develop an SRS system. We are happy now that what the system is telling us is true. We're happy with our choice of a mobilisation kit. We know that our patients aren't moving in that. So we're now going to start working in the next 6 months towards delivering an SRS case. And also, it's maybe controversially, we want to sort of look towards if we can set up our patients with a single radiographer model. We want to look if actually this system is good enough to act as our second radiographer from a resource point of view, so that maybe we can free radiographers up for planning. We can free them up to do, more patient-orientated tasks, review clinics, etc. That will be a big piece of work, but it is something that we're going to look at. And then we're going to look at further SGRT rollout in the UK. So we've had a system installed in another centre so that we can start to gather a lot more data a lot quick with more patients going through the system. So that's it from me, but thank you for having me over here. Thanks very much.
You said that you do the no tattoo treatment. Do you have Vision RT in your CT sim and you export the DICOM? Is that how you're doing the digital tattoos?
So what we actually use our lasers in CT, so we are looking to put a gate CT system in. What we do at the moment is we coach our patients and we aim for a level of breath hold from the lateral laser, so we will always achieve 2 centimetres. And again, that's come from audit data that is around an average good breath hold. We also looked previously at our past patients and what they achieved by measuring from their DICOM data in the TPS, and 2 centimetres is about right for a breath hold. And we've actually found that works really well. Obviously now we're happy with the system and we know that we'll keep it. We'll look towards putting a more formalised solution in, such as gate CT.
So how do you line them up, though, on their first day with no external marks?
Yeah, so our breastboards that we have are scaled, so we've got numbers down the side, so we'll make sure that, we'll make sure that on both sides of the breastboard that we're aligning to, 15 centimetres through the breast, and we'll take a reference mark from SSN down to midline, or that whatever you've sort of determined off your breastboard. And then that's recorded, and then on the first fraction we'll actually draw those pen marks on the patient, just check that everything is setting up as we would expect, and then from then on we don't really need to.
Great, thank you.
It's pretty easy.